Failure of non-invasive support occurs when the infant can no longer maintain gas exchange or protect the airway despite optimal settings. Recognizing these thresholds early is essential because delaying intubation allows progressive hypoxemia, acidosis, and fatigue, which worsen outcomes once invasive ventilation becomes necessary. The first indicator of failure is persistent hypoxemia. When oxygen saturations remain below 88 to 90%, despite oxygen at or above 60% on appropriately applied CPAP, HFNC, or NIPPV, alveolar recruitment is no longer sufficient to sustain oxygenation. Continued non-invasive therapy at this point only prolongs instability. Failure to ventilate is identified by carbon dioxide levels above 65 to 70 and a pH below 7.25, showing that the infant's minute ventilation is inadequate even with maximal non-invasive support. Without prompt escalation, worsening acidosis will depress respiratory drive and further compromise gas exchange. Airway protection is another critical factor. Recurrent apnea requiring stimulation or bag mask ventilation or clinical signs of poor perfusion and shock indicate loss of effective respiratory control. In these cases, maintaining non-invasive support poses more risk than benefit. Once these criteria are met, intubation should proceed without hesitation. Early transition to invasive ventilation stabilizes oxygenation and ventilation, prevents further metabolic stress, and avoids the harm associated with prolonged hypoxia and respiratory failure. Rapid sequence intubation provides a controlled approach to securing the airway while minimizing pain, hypoxemia, and trauma. The goal is to maintain physiologic stability throughout the procedure. Pre-oxygenation to 100% and full monitoring are essential because neonates desaturate quickly due to small functional residual capacity and high oxygen consumption. Suction and equipment must be ready before medications are given. The medication sequence is deliberate. Atropine at 0.02 milligrams per kilogram is given first to block vagal bradycardia caused by airway stimulation. Fentanyl at 2 micrograms per kilogram follows to provide analgesia and blunt the sympathetic surge that can elevate intracranial and pulmonary pressures. Both agents should be administered slowly and before the paralytic to prevent chest wall rigidity and ensure adequate analgesia. Once the infant is stable, a neuromuscular blocker such as rocuronium 1 milligram per kilogram or succinylcholine 2 milligrams per kilogram is given to achieve complete relaxation. Intubation proceeds only after full paralysis to minimize airway trauma and ensure a single, smooth attempt. Placement must be confirmed immediately. A colorimetric carbon dioxide change remains the gold standard, supported by equal bilateral breath sounds, symmetric chest rise, and improvement in heart rate and oxygen saturation. The structured RSI sequence lowers the risk of desaturation, bradycardia, and intracranial pressure fluctuations that can accompany uncontrolled intubation. By coordinating timing, medication sequence, and physiologic monitoring, RSI achieves a safe and effective airway with minimal instability. In the newborn, the airway tapers at the cricoid cartilage, which forms the narrowest portion of the upper airway. This anatomic shape allows an uncuffed endotracheal tube to create a gentle seal at the cricoid without the need for an inflated cuff. Because of that natural seal, uncuffed tubes remain the standard of care for most neonates. Using an uncuffed tube protects the airway mucosa from pressure injury and subglottic stenosis, and it significantly lowers the risk of post-extubation stridor. The absence of a cuff also simplifies management. There is no need for cuff pressure monitoring, and secretions are easier to clear through the leak. Ventilation efficiency is preserved because for a given outer diameter, an uncuffed tube provides a larger internal diameter and therefore lower resistance to flow. The presence of a small, audible leak confirms that the tube fits gently and is not exerting pressure on the mucosa. Altogether, the uncuffed tube design uses the infant's anatomy to achieve a physiologic seal, providing effective ventilation while minimizing airway trauma. Cuffed endotracheal tubes are not routine in neonates, but are appropriate in specific situations where precise pressure control or airway protection is required. They are most useful during surgical or long-term ventilation when maintaining an exact seal is necessary for consistent airway pressures or gas delivery. A cuffed tube may also be indicated when there is a high aspiration risk or when accurate end-tidal carbon dioxide measurement is essential for tight ventilator management. If a cuffed tube is chosen, it should always be a microcuff design sized for the neonatal airway. The cuff is inflated only enough to create a seal, and pressure must remain at or below 20 centimeters of water to avoid mucosal injury. Excessive inflation can exceed mucosal capillary pressure and cause ischemia, edema, or subglottic damage. Even when a cuffed tube is used, the cricoid ring continues to provide the physiologic seal unique to the neonatal airway. The uncuffed approach remains preferred for most infants because it uses that natural anatomy to achieve effective ventilation with the least trauma. Selecting the correct endotracheal tube size is critical for safe and effective ventilation. The size must balance adequate airflow with protection of the airway mucosa. Two quick methods guide sizing. The first is the 1-2-3 rule. For infants between 1 and 2 kilograms, a 3.0 tube is appropriate. The accompanying weight table extends this pattern. A 1 kilogram infant typically needs a 2.5 tube, 3 kilograms a 3.5, and 4 kilograms a 4.0. An alternate approach uses gestational age. Infants below 28 weeks generally require a 2.5 tube, those 28 to 34 weeks a 3.0, and term infants a 3.5 or 4.0, depending on airway size. Both methods typically yield similar results and should be confirmed clinically. A small intentional leak of 10 to 20% is acceptable and confirms that the tube is not exerting circumferential pressure on the cricoid. The goal is a seal adequate for ventilation, but loose enough to protect the mucosa. Always prepare one size smaller as a backup in case of resistance during insertion or unexpected airway narrowing. Proper sizing at the outset helps avoid high resistance, mucosal injury, and unplanned reintubation later in care. Endotracheal tube depth is determined by the infant's weight and must position the tip in the mid-trachea to ventilate both lungs evenly while avoiding main stem placement. A simple and reliable method is the weight-based formula. Tube depth in centimeters equals the infant's weight in kilograms plus 6. This aligns closely with the traditional 7-8-9 rule. At 1 kilogram, the tube should be at 7 centimeters at the lip, at 2 kilograms 8 centimeters, and at 3 kilograms 9 centimeters. For nasal intubation, add 1 to 2 centimeters to account for the longer pathway through the nares and nasopharynx. After placement, the goal is to visualize the tip 1 to 2 centimeters above the carina, generally between the first and second thoracic vertebrae on chest radiograph. Tubes positioned too shallow risk accidental extubation or leak, while those too deep often enter the right mainstem bronchus and cause unilateral expansion. Recheck tube depth whenever the infant is repositioned or as growth occurs during prolonged ventilation. Even small changes in head or neck position can shift the tube several millimeters and alter placement. Consistent use of the weight-based formula and confirmation by radiograph or bedside assessment ensures reliable placement and prevents airway complications. Verification begins immediately after intubation, using physiologic response, clinical observation, and objective confirmation. An improving heart rate and oxygen saturation are the earliest signs of correct placement. Observe for equal chest rise and visible condensation in the tube during exhalation. A colorimetric carbon dioxide detector is the preferred bedside tool. The colors shift from purple to gold, or a consistent capnography waveform, indicates tracheal placement and effective ventilation. Auscultate both lungs and the epigastrium. Equal bilateral breath sounds with no gastric air entry confirm that the tube is above the carina and not in the esophagus or right mainstem bronchus. Radiographic confirmation follows stabilization. The tip should lie 1 to 2 centimeters above the carina, generally at the first to second thoracic vertebral level, with equal lung inflation and no gastric distension. Ongoing assessment includes end-tidal carbon dioxide monitoring, exhaled tidal volume, and checking the centimeter mark at the lip or nair after any repositioning or movement. The purpose of conventional mechanical ventilation is to support oxygenation and ventilation when non-invasive support is no longer sufficient. Ventilation provides adequate gas exchange while protecting the lung from injury. Each setting must balance oxygen delivery, carbon dioxide removal, and lung protection. In the neonate, this balance is delicate. Tidal volumes are small, usually 4 to 6 milliliters per kilogram, and even minor overinflation can cause volutrauma or barotrauma. Maintaining alveolar recruitment without overdistension prevents atelectrauma and reduces the risk of bronchopulmonary dysplasia. The neonatal chest wall is highly compliant, while the lungs are relatively stiff. This mismatch contributes to alveolar instability and the need for positive pressure to maintain end expiratory volume. Ventilation also compensates for immature respiratory drive and limited reserve. Controlled support prevents hypoxemia and hypercarbia, both of which can impair cerebral and cardiac function and increase the risk of intraventricular hemorrhage. Conventional ventilation therefore serves as both a supportive and protective measure, maintaining stability until spontaneous respiratory function can sustain gas exchange independently. During mechanical ventilation, all inspired gas must be heated and humidified to approximate physiologic conditions within the lower airway. The goal is a temperature near 37 degrees Celsius and full saturation at 44 milligrams of water per liter. Dry or cold gas injures the airway epithelium and impairs mucociliary clearance. This promotes secretion thickening, airway plugging, and atelectasis, which can progress to infection or chronic lung disease. In neonates, these effects develop quickly because the small caliber airways and high surface area make them highly susceptible to drying and heat loss. Even short exposure to inadequately conditioned gas can lead to mucosal inflammation and increased airway resistance. Proper humidification also preserves surfactant function and reduces the risk of airway bleeding or sloughing during suctioning. Heated humidification is therefore essential for both invasive and non-invasive respiratory support. Every ventilator circuit should include an active heated humidifier with continuous temperature control to maintain stable humidity delivery throughout the breathing circuit. Heated humidifiers are the standard method for conditioning inspired gas during both invasive and non-invasive ventilation. These systems warm water to produce vapor rather than aerosol, maintaining a consistent temperature and humidity throughout the circuit. Passive devices such as heat-moisture exchangers are rarely suitable for neonates. They add dead space, increase airway resistance, and can become obstructed with secretions. In small tidal volume ventilation, even minor dead space increases can impair carbon dioxide clearance. Other systems such as bubble or passover humidifiers do not generate sufficient humidity for positive pressure ventilation and are therefore inadequate in this population. Several challenges affect humidification. Condensation, or rainout, occurs when warm, saturated gas cools in the circuit, creating pooled water that increases resistance and infection risk. Overhumidification can narrow the airway and add systemic fluid burden. Leaks, especially with CPAP or high-flow nasal cannula, wash out humidity and reduce effectiveness. Consistent heating, vigilant circuit management, and minimizing leaks are essential to maintain optimal humidity and protect airway integrity during mechanical ventilation. Before discussing modes, it's important to review the key variables that describe how a ventilator functions and how the lung responds. Peak inspiratory pressure, or PIP, is the highest pressure reached during inspiration. It reflects the force used to deliver each breath and is limited to prevent barotrauma. Positive end expiratory pressure, or PEEP, is the pressure maintained at end expiration to keep alveoli open and prevent collapse. Mean airway pressure, or MAP, is the average pressure across the respiratory cycle and is the primary determinant of oxygenation. Inspiratory and expiratory time, or T and T, define the duration of each phase of the breath and together determine the inspiratory to expiratory ratio. Tidal volume, or VT, is the amount of gas delivered with each breath and controls carbon dioxide clearance. Three derived concepts describe the mechanical properties of the lung. Compliance is the change in volume for a given change in pressure, low in RDS and high in BPD. Resistance represents opposition to airflow and increases with small tubes or obstruction. The time constant, equal to compliance multiplied by resistance, defines how long it takes the lung to fill or empty. Short time constants require short inspiratory times. Long constants require longer expiratory phases. Ventilator settings are the operator inputs that define how the ventilator delivers each breath, while measurements are the physiologic outputs that reflect how the infant's lungs respond. Settings include peak inspiratory pressure, positive end expiratory pressure, inspiratory time, rate, and fraction of inspired oxygen. When using volume guarantee or volume-targeted ventilation, the set tidal volume determines the delivered pressure required for each breath. Additional parameters such as trigger sensitivity, rise time, and pressure support influence synchrony and flow pattern. Measurements include mean airway pressure, plateau pressure, compliance, and resistance. Mean airway pressure represents the average pressure across the cycle and determines oxygenation. Plateau pressure reflects alveolar pressure at end inspiration and signals risk for overdistension. Compliance and resistance define how easily the lungs fill and empty. Monitoring synchrony, exhaled tidal volume, and work of breathing connects these measurements back to patient effort and overall ventilator performance. Pulmonary mechanics describe how the lung and airways respond to pressure and flow during ventilation. Three main variables define this relationship: compliance, resistance, and the time constant. Compliance is the change in volume for a given change in pressure. Normal neonatal compliance is about 3 to 5 milliliters per centimeter of water per kilogram. In respiratory distress syndrome, compliance may fall below 1, reflecting stiff, surfactant-deficient lungs that require higher pressures for small volumes. Resistance is the opposition to airflow, determined by airway diameter and gas flow rate. Normal resistance is 25 to 50 centimeters of water per liter per second. It rises with small endotracheal tubes, airway obstruction, or evolving bronchopulmonary dysplasia. The time constant, calculated as compliance multiplied by resistance, represents how quickly the lung fills and empties. A short time constant, seen in RDS, means rapid filling and short inspiratory time. A long time constant, typical of meconium aspiration or BPD, indicates slow emptying and the need for a longer expiratory phase to prevent gas trapping. These relationships guide adjustments to inspiratory and expiratory times, pressures, and rates during mechanical ventilation. Each breath delivered by the ventilator or patient can be described by how it is initiated and cycled. Recognizing these breath types is essential for interpreting mode function and synchrony. A mandatory breath is completely ventilator-driven. It may be triggered by time or by the ventilator's preset rate, and the machine controls both inspiration and expiration. The infant performs no work of breathing. A spontaneous breath is entirely patient-driven. The infant initiates and terminates inspiration based on their own effort, while the ventilator provides only baseline pressure such as PEEP. These breaths reflect true spontaneous ventilation. An assisted breath is patient-triggered but ventilator-supported. The infant starts the breath, and the ventilator delivers additional pressure or flow to reduce work of breathing. Examples include SIMV with pressure support and NAVA. Identifying whether a breath is mandatory, spontaneous, or assisted defines how a mode interacts with patient effort and determines how synchrony will appear on ventilator waveforms. The phase variables framework defines how the ventilator controls each phase of the breathing cycle. Every mode can be described by 4 variables: trigger, limit or target, cycle, and baseline. The trigger is what starts inspiration. It may be time-triggered by the ventilator or patient-triggered by a change in flow, pressure, or neural activity. Recognizing the trigger helps assess synchrony and effort detection. The limit or target is the maximum value the ventilator maintains during inspiration, such as a set pressure, volume, or flow. In pressure-controlled ventilation, inspiratory pressure is the limit. In volume-targeted ventilation, the tidal volume becomes the goal variable. The cycle defines what ends inspiration. This can be time, flow, volume, or a decline in neural drive depending on the mode. Matching the cycle to the infant's own inspiratory timing prevents breath stacking or premature cycling. The baseline is the pressure maintained during expiration, typically the PEEP, which preserves functional residual capacity and prevents alveolar collapse. Using these variables provides a consistent way to describe all ventilator modes across different devices and manufacturers. The cycle variable determines what ends inspiration. Understanding it helps interpret ventilator graphics and adjust settings for synchrony and tidal volume control. In time-cycled modes, inspiration ends after a preset inspiratory time. This provides consistency, but may mismatch the infant's natural inspiratory effort. If the set time is too short, the breath ends before full inflation. If too long, the infant may attempt to exhale while pressure remains positive. Time cycling is used in pressure-controlled modes such as assist/control and SIMV. Volume-cycled ventilation ends inspiration once a preset tidal volume has been delivered. This approach works well in systems with minimal leak, but is less reliable in neonates, where leak around an uncuffed tube can cause early termination or inaccurate measurement. Flow-cycled modes end inspiration when inspiratory flow decreases to a set percentage of its peak value. This pattern follows the patient's effort and provides better comfort and synchrony. It is characteristic of pressure support and SIMV with pressure support. Neural cycled ventilation, used in NAVA, ends inspiration as diaphragmatic electrical activity declines. This most closely mirrors the infant's natural breathing rhythm. The trigger mechanism determines what starts inspiration. Recognizing how each trigger functions is essential for identifying patient ventilator synchrony and minimizing missed or auto-triggered breaths. In time-triggered modes, the ventilator delivers breaths at a fixed rate independent of patient effort. This provides consistent ventilation during apnea, but can create asynchrony when the infant's spontaneous effort does not match the timing of mandatory breaths. Pressure-triggered systems sense a small drop in airway pressure generated by the patient's inspiratory effort. While once common, this method is less reliable in neonates because leaks around the tube or weak inspiratory effort may prevent detection. Flow-triggered ventilation is now standard in neonatal care. It senses a change in baseline flow within the circuit, allowing faster detection of patient effort with improved synchrony and reduced work of breathing. Neural-triggered ventilation, as used in NAVA, detects diaphragmatic electrical activity through an esophageal catheter. This allows the ventilator to respond immediately to neural drive, even before changes in flow or pressure occur, providing near-perfect synchrony. Because ventilator mode names vary across manufacturers, a standardized classification is used to describe function consistently. Each mode is defined by 3 core elements: the control variable, the breath sequence, and the targeting scheme. The control variable specifies what the ventilator regulates during inspiration, pressure or volume. In pressure-controlled modes, the ventilator maintains a set pressure and allows tidal volume to vary with compliance. In volume-controlled or volume-targeted modes, a consistent tidal volume is delivered while the pressure adjusts to achieve it. The breath sequence defines how mandatory and spontaneous breaths are combined. In mandatory sequences, all breaths are ventilator-initiated and ventilator-cycled, providing full support as in assist control. Spontaneous sequences depend entirely on patient effort for both initiation and termination, as in pressure support or CPEP. Intermittent sequences combine the two, giving mandatory breaths at a set rate while allowing spontaneous breaths between them, such as in SIMV. This pattern allows partial support and smoother weaning. The targeting scheme describes how the ventilator meets its control target and how it adapts to changes in the patient or lung mechanics. Set point modes use fixed operator settings with no automatic adjustment. Dual targeting can switch between 2 control variables, such as pressure and volume. Servo and adaptive systems continuously adjust to maintain consistent ventilation. Optimal and intelligent algorithms use feedback and predictive logic to achieve goals like stable minute ventilation or reduced work of breathing. Every ventilator mode can be described by how each breath begins, what is controlled, and what ends inspiration. This structured approach removes manufacturer-specific names and focuses on function. The trigger defines what starts inspiration. It may be initiated by time, patient effort detected by flow or pressure change, or by neural activity in modes like NAVA. Understanding the trigger identifies how the ventilator synchronizes with patient effort. The control variable, or target, is what the ventilator regulates during inspiration, either pressure or volume. Pressure control maintains a set pressure and allows volume to vary, while volume control delivers a fixed volume and allows pressure to vary. The cycle variable determines what ends inspiration. This may be time, flow, volume, or neural signal, depending on the mode. Proper cycling alignment prevents premature or delayed termination of inspiration and improves synchrony. The breath sequence classifies the overall pattern: continuous, mandatory, intermittent mandatory, or fully spontaneous. Using these taxonomic variables allows consistent description of any ventilator mode, clarifies how settings affect patient interaction, and provides a framework for comparing modes across devices. The control variable defines what the ventilator maintains during inspiration, either pressure or volume. This distinction determines how each breath adapts to changes in compliance and resistance. In pressure-controlled ventilation, inspiratory pressure is fixed while flow and tidal volume vary. The ventilator maintains a set pressure, producing a decelerating flow pattern. This limits barotrauma and helps recruit alveoli in non-compliant lungs, such as respiratory distress syndrome. The risk is variable tidal volume when compliance changes. In volume-controlled or volume-targeted ventilation, the tidal volume is fixed and the pressure varies. This ensures stable minute ventilation and more predictable carbon dioxide control, but can result in higher peak pressures when compliance worsens. Hybrid modes such as pressure-regulated volume control or volume guarantee combine these principles. The ventilator delivers a pressure-controlled breath but automatically adjusts pressure to achieve a consistent tidal volume. At the bedside, neonatal practice favors volume-targeted pressure control because it provides consistent tidal volume while limiting pressure swings. Typical target volumes are 4 to 6 milliliters per kilogram for preterm infants, with slightly higher volumes only in restrictive conditions such as meconium aspiration.